Everyone, welcome back. Today we're joined again by Dr. Stenehjem to go over our community update on COVID-19 in the state of Utah. Eddie, thanks for joining us. We really appreciate the time as always.
Of course.
So I want to talk about case counts. The data has been released for today, so this information is as of 1 p.m. today. Our total case count in the state of Utah is 45,424. Our daily case counts were 334 with a positive rate of 8.6%. We have 353 deaths total with 2 new as of today and 2,721 hospitalizations with 25 new as of today. Let's break down those trends a little bit, talk to us about how our hospitals are doing and whether you think that positive rate is moving in the right direction.
Yeah, I mean, you can't deny it. I mean, we are moving absolutely in the right direction. We definitely seem to have kind of come up and over this peak and are now, in terms of daily case counts, to started to decline nicely and has a continuing trend downwards. That's in conjunction with decreased testing as well. You have to start thinking, well, why is it that we have decreased testing? Is it due to the fact that we have lower community-based transmission? Certainly possible. Is it because people are becoming more and more aware of what symptoms truly are of COVID-19? And so we're just testing people that have true and legitimate symptoms. That might be the case. So there's a lot of things that go into that decreased testing component. But regardless, what we're seeing is a really nice decrease in daily case counts. And you have to say, okay, what are other complementary measures that would potentially support a decrease in community transmission? And one of the things that we're seeing is that we're having decreased hospitalizations. And this is exactly what we wanted and what we've asked for from a healthcare standpoint, is we got to decrease our, the intensity and the burden on our healthcare network. And what we've seen now is, at Intermountain Medical Center, for example, we were running daily census between 40 and 50 patients with COVID-19. Now this morning, when we rounded on the COVID patients, we were at 29, I believe. And so, we still have plenty of really sick people in the hospital that are really struggling to survive. But that said, we're having a decrease in case counts across the system. And so that just is kind of another marker to show that we're headed in the right direction. One of the other metrics that we look at and people have been focusing on is this percent positivity. And that has decreased from about 9, 10, now it's down to 8. That's a hard metric to really look at, especially if the people that are getting tested is changing and if the positive cases are occurring in different demographics that may or may not get tested. And so that's something that we're really kind of looking at in terms of whether or not that truly is indicative now of community-based transmission, and is it really a reality to drive that to 5%? That's going to take some more investigation in terms of what that actually means and what's changed in terms of the population being tested here in Utah.
As far as the age category too, that's having more of a positive test come back, has that changed at all in the last couple of weeks, or is it still towards the younger age demographic that it's affecting?
Yeah, when you look at the total numbers of who's getting infected, that 15 to 24-year-old age group has certainly had the biggest increase in the past month or so. But when you start to look at where have we seen declines, we've seen them in all age groups for the most part. We've seen nice declines throughout, but significantly a pretty significant emphasis in the 15 to 24-year-olds as well. I suspect that the reason we're seeing these decrease in case counts is people are masking up, people are washing their hands, and they're really kind of focusing on, oh boy, we got to get our kids back to school. How are we going to do that? We need to decrease community transmission. And, the mask mandate in Salt Lake County, I think certainly helped this. And we're seeing more and more use in other areas of the state as well.
Let's talk a little bit about masks too. There was a recent study that came out about different types of face masks and the effectiveness of those. And they actually said that buffs or fleece gaiters are the least effective, and they're actually less effective than wearing no mask itself. Can you talk a little bit about that study and what it means for the public if you were the person that was wearing a ski gaiter or a bandana around your face before?
Yeah, it's really interesting. This is most likely the first of probably many studies that are going to come out evaluating different types of face coverings. Um, Keep in mind that up until now, the studies have been in surgical masks and N95, those really tight-fitting hospital-grade masks that we use with airborne isolation precautions. And we didn't have a ton of data on the true effectiveness of different types of face coverings. And so this is a really welcome addition to the literature. And what this study looked at is looked at the number of particles that are excreted from your mouth while wearing different types of face coverings. It didn't account for how they protected you as an individual. What they looked at is how well they stopped the transmission of essentially water droplets from your mouth out into the environment. That's what it really looked at. With a nice kind of elegant design. And so it really looked at multiple different types of face coverings. They looked at N95s, they looked at surgical face masks, they looked at N95 with the exhalation port, a whole slew of different cotton blends and cotton polypropylene blends, and then also bandanas and what they called fleece gaiters. But the picture in the report looked like a standard fleece that we would all wear potentially, out skiing or whatever it might be, but not a true fleece material. And what it showed was that the surgical masks that we see out and about are probably the best. And the fact that they reduce over 95% of those droplets coming from your mouth if worn correctly. But I think reassuringly, it showed that most of those cotton type face coverings, those especially with 2 or 3 layers, reduce the number of droplets by over 80%. And so that I think is really encouraging data to show that wearing one of these cotton face coverings is very effective in terms of decreasing the viral burden into the community. But what should be noted that bandanas and also these gaiters did very little. And in fact, the bandana reduced the excretion of particles by maybe 20%. And those fleece gaiters actually increased the particles. And the thought was that those fleece gaiters actually thought they broke up the bigger droplets and scattered them more to actually increase the number of viral particles or water droplets that they measured here. So I think it's a really good study to really kind of help us understand what's probably most effective. And in the community, it's a 3-layer cotton face covering. There's also the polypropylene and cotton blends that seem to function really well. And then also a surgical face mask was probably the best. The N95s did really, really, really well. Those are real uncomfortable to wear outside, especially when it's warm. And we need to make sure that those are available for our hospital-based employees as well.
I think it's interesting that there's now this study coming out about cloth masks because there, like you said, there hasn't been a ton yet. It's mostly been on surgical and N95s. And it'll be interesting to see what happens over the next couple of months as more and more studies come out about that. I think that reassures the public, hopefully, that by wearing a cloth-based mask, you're helping protect those around you. So things like that are great to hear. And we can post that study afterwards if anyone wants to look over it themselves too. I want to talk a little bit about misinformation and go over some recent rumors that have been circulating around the internet and just kind of get your opinion on them. So one of them is that our ICUs are always this full and that we're not really seeing this increased capacity of patients due to COVID. Will you talk a little bit about that one specifically?
Yeah, I mean, I can't speak specifically to the capacity numbers of our ICUs that run, in May, June, July, and years previous. What I can speak to is the fact that I've never seen our ICUs this busy, and I've never seen an ICU since I've been in medicine that has been dedicated to one type of infection and one type of infection only. And to walk into an ICU and see 10 patients on a ventilator or on severe respiratory distress due to one type of infection, that's unheard of. And so this is not business as usual for us. This is not kind of what we expect to see in the middle of summer. And it's certainly, something that we don't like to see just because it leads to worse outcomes. Fortunately, right now, we still are at our capacity where we can manage these patients in effective manners. And so we haven't had to go to a surge capacity. Once we go above about 80 to 85% of our ICU capacity, that's when we start getting into real trouble in terms of bed space. That's when we start thinking about having to branch out your ICU into non-ICU care settings and having, ICU level patients being taken care of by non-ICU trained people. So fortunately, we're not there. And actually, this decrease in case counts in the hospitals that have really kind of been followed by a decrease in community-based cases has done a lot for us and really given us some breathing room in our ICU. So this is definitely not business as usual. This is busy ICUs that I have never seen like this before, especially in the midst of summer.
Another one that keeps coming up too is that doctors are withholding treatments, specifically hydroxychloroquine. That came up again, that we're not prescribing patients drugs that we know work. Will you speak a little bit to that?
Yeah, I'd love to speak a lot to that, in fact. So, we would love it if hydroxychloroquine was an effective therapy, right? It's an oral therapy. It's relatively safe. It's available. It's FDA approved. That would be ideally. That would be right. That'd be our ideal therapy for COVID-19 if it worked. Now, when we evaluate treatments in infections, or whether it be hypertension or anything like that, we really focused on what does the data show. And so we do studies that are called randomized controlled trials. And typically these are double-blinded randomized controlled trials. So the patient doesn't know the medicine that they're on, and neither does the physician. And in these type of trials, we randomize patients to receiving, in this case, hydroxychloroquine or not hydroxychloroquine, and we see which has better outcomes. And so now, in the past about a month or so, we've had a number of randomized controlled trials come out that has assessed the utility of hydroxychloroquine. And so we've seen 2 trials that have come out that assess its use in preventing COVID-19 in people that have been exposed to coronavirus. We've seen studies that have looked at the use of hydroxychloroquine in people with mild to moderate symptoms. And then we've seen randomized controlled trials that have come out in people that have severe symptoms. None of the randomized controlled trials that we've seen have been published have shown any effect of hydroxychloroquine in terms of mortality or decreasing symptoms or decreasing length of stay. What we have seen is we've seen what are called retrospective cohort trials that have shown a signal that maybe hydroxychloroquine's worked in some trials and it certainly hasn't in others. Those studies are kind of a second tier quality-based study because you are taking people that were prescribed hydroxychloroquine for a reason. They are likely going to be different than the people that weren't prescribed hydroxychloroquine. And you try to account for those differences with statistical models, but you just can't do that. And so we go to retrospective cohort studies when we don't have access to randomized controlled trials. In this case, we have very good randomized controlled trials that show that hydroxychloroquine has no benefit in prevention, mild to moderate disease, or severe disease. And so because of that, we don't use it. And it's not a drug that we provide our patients because we think that it's going to cause more harm than good. Now, we do provide lots of other therapeutics for COVID-19 that have been proven safe and effective. Okay, so remdesivir is an antiviral drug that has been shown in clinical trials, including randomized controlled trials, to decrease length of stay. And there's a trial coming out that likely is going to show decreased mortality. So that's a drug that we do give our patients if they are on over 4 liters or more of oxygen. The other drug is steroids, or in particular dexamethasone. So this was the recovery trial, randomized controlled trial in the UK, showed a mortality benefit. And so we give that to patients. In addition, we're giving convalescent plasma. This is a plasma that we get from people that have recovered from COVID-19, have antibodies against COVID-19, and we can give that to people that are acutely infected. Now, we have observational cohort studies that show that that's of benefit. We haven't seen a randomized controlled trial to show that that is of benefit yet, but once we have that data, we'll make the determination whether we'll continue to use that or not, just like we did with hydroxychloroquine. Now, so those are the 3 agents that we are routinely using in all of our facilities, regardless if you're, admitted down at Utah Valley Hospital, St. George Hospital, or Intermountain Medical Center. Those are the standards. And there's lots of other medications that are being evaluated as well.
As far as plasma goes as well, how are we getting those donations? How do you donate? What's the process like for that? How do you get involved if you wanted to?
We highly, highly, highly encourage people that have recovered from COVID-19, that have been acutely ill from it, and have recovered from COVID-19 to go and donate at the Red Cross. That's incredibly important, and we would really love to get this word out more. If you've been, even if you're at home and had mild disease but had gotten tested, go to the American Red Cross and donate your plasma. This is providing a resource to the people that are in the hospital and sick, that haven't had the time to generate an antibody response. And so American Red Cross is where they're getting donated. You also, if you donate to American Red Cross, you can find out if you're antibody positive for COVID-19. So even if you want to go donate blood for the sole reason to know your antibody status, American Red Cross will do it. And we would really encourage people, especially those that have recovered from COVID-19, to go and donate.
And we'll put up some resources for that after this, so you guys can look at them. They're like Eddie said, it's a great way to find out if you were positive for it as well, which is nice. I want to switch gears a little bit to schools. In Utah, there are a couple of counties that have already started schools, and a lot of them are starting in the next couple of weeks. And I want to talk a little bit specifically about sports. Across the US, a lot of college football seasons have been postponed. That happened pretty recently. The Pac-12 announced this week that they're not going to be playing their season, and high school sports are still continuing. There was a report that came out today that the first game of in the country was supposed to be played for high school in Utah between Weber and Bingham High, and they ended up having to cancel it due to members of the Bingham football team testing positive. What does this all mean for sports, and how are parents supposed to decide whether their children should be playing? Is there any good way to go about sports for this season?
This is going to be really hard. And I mean, what a disappointment, right? I mean, I think I speak for the majority of people that, love college football and really enjoy, watching the Utes or whatever their favorite team is. I mean, that's just part of fall, for us. And it's really a disappointment that we couldn't have controlled this epidemic enough to where that could go on. I certainly support the Pac-12 decision and other, divisions that are canceling as well. In reality, football is a close contact sport. It's a lot of heavy breathing. It's a lot of close contact. That is a perfect way to transmit the infection. And I think they knew that. And that's, the reason that they had to call off the season, is because they couldn't guarantee the safety of their athletes. And that was their primary concern. And so I applaud them for, focusing on that. Fall sports is going to be challenging, not just for collegiate fall sports, but also for high school and, other fall sports as well. And, you have to look at these individual sports by themselves. Football, for example, like we said, it's going to be a high risk sport. Singles tennis, maybe not so much, because you're separated, by space, and, you can certainly probably, play singles tennis without a whole lot of risk. And you're going to have to take these one by one. And the minute that you see a positive case, you're going to have to be willing to be flexible enough to shut it down and test the entire team. And so, just like schools are going to have to be flexible and react to outbreaks, and that they will happen, the same thing is going to be said about fall sports. And if, you as a parent, are sending your kids back to fall sports, and maybe your child has one of the high risk features of a comorbid illness, whether it be severe asthma, you're really going to have to contemplate whether or not fall sports is right for you and your family. And potentially, maybe, you as a parent have a complicated condition, or you live with your parents, so these decisions are going to have to be very individualized and assess risk, both with the sport itself, the child, and also the family environment.
I think it's interesting. There's been professional sports that have started to go back. They went back a couple months ago, and baseball was a sport that did not go greatly for people. I don't know if it's still continuing now, but they had a lot of cases, whereas hockey and the NBA created these almost bubbles of people where they were quarantined with that bubble. They're not allowed to leave. They're all in the same place. And that's what's a little bit different with high school sports, is that you're traveling constantly. You can't just stay in this little bubble and hope that no one gets it. So yeah, it'll be interesting to see what happens the next couple of weeks, and the NFL has to make that decision too. So we'll see what happens there. But let's talk a little bit about the actual school portion of school too. There's obviously plans in place for what happens if a school does end up having to quarantine or a classroom. What are some ways that schools can start thinking about those plans to make sure that those don't happen? Like, what are some ways that they can actually be proactive and say, okay, we're going to do this, this, and this, so that way our kids can still stay in school?
Yeah, so I think schools are going to have to be, just like we talked about sporting events, they're going to have to be incredibly flexible as they start going back to school. And some actually went back today. And so, I think a couple of the big principles that have got to be focused on. One is as much as you can within your classroom, spread people out. Granted, our large class sizes make this a challenge and it's a big limitation, but this is one of the reasons why a hybrid model is, thought to be, a very, a model that would potentially work well, is because you're really separating the class in half and you're decreasing the number of people actually in the classroom. So that's first and foremost. If you can separate as much as you can, face masks, absolutely critical in terms of decreasing the spread and the transmission from that. And then obviously having an idea in terms of hand hygiene and looking at high touch places and how can you avoid that, not sharing, writing utensils and some of those things that really increase what we call fomite transmission. The next thing schools really are going to have to focus on is cohorting classes or cohorting grades. And so if a class is only exposed to those people in the class, then if and when you have an outbreak in the class, you don't have to shut the entire school down. You just have to isolate that classroom. As opposed to if you had a classroom that goes to a lunchroom and is exposed to everybody in the lunchroom, and now you've got people in one class infected, now you potentially have to shut down the entire school or those people that are in the lunchroom. So I think focusing on cohorting is going to be critical in addition to those other measures. And then if at all possible, try to increase the ventilation in those classrooms. And so can you open the windows? Can you put in fans? Can you open the door? Anything you can do to help circulate that air is going to decrease risk, along with your face mask and your separating the children as much as possible. In the end, we're going to see outbreaks. I mean, we're going to have community-based transmission. This isn't going to go away. And we will have outbreaks in the classes, and we're going to have to be flexible enough to react to them, and hopefully be able to make sure that if you do have to, quarantine an entire class, that they can go back to school remotely while they're waiting during their quarantine period before they come in, to make sure that our children keep learning and keep having that social interaction. It's going to be a challenge for school teachers and kids alike, and we hope that they have the flexibility to, maintain some level of education as we move through the fall.
Last question for you. The governor, during his press conference today, announced that face shields were considered okay for children, but they had to be worn in conjunction with a face mask. Having a face shield and a face mask on, does this provide any sort of additional protection for the child or the people around them?
Yeah, I think the consensus is yes, as long as it's worn in conjunction with a face mask. I mean, keep in mind our eyes are mucous membranes, and so you can get infected, through your eyes. And so all healthcare workers are wearing, face masks and eye protection, whether it's a face shield or goggles. And so absolutely protecting your eyes is another barrier, and having another, shield or barrier in front of you before your mask is also going to decrease exposure and risk if you're exposed to somebody who is COVID-19 positive. So yes, I think it absolutely does, but it's another thing to have on your face. The other thing that it does is it really prevents you from touching your mask and touching your face. And so, when I wear a face shield at, when I'm seeing patients in the hospital, you can't rub your eyes through it. You have to very consciously lift your face shield to touch your face. And so it definitely is another barrier from a manipulation standpoint. Whether or not just the face shield by itself without a face mask offers much protection, I think is up for debate. It certainly doesn't have that seal like a mask does, and you're probably still transmitting virus around it. I haven't seen any data on that. It may be out there, I just haven't seen it.
Eddie, is there anything else you wanted to mention to us today about what's been happening in the last week?
Yeah, I mean, it's not been often that I've been optimistic in the past 4 to 5 months, in complete honesty. but the trend we're seeing is encouraging. And I think that is our community kind of rallying and focusing on, listen, we got to get our kids back to school. We got to do this safely. And, I would just encourage everybody to keep wearing their masks. Just because our community cases are going down, this is not the time to get lax. This is not the time to start going out. This is not the time to start gathering in big groups. In fact, this is the time to continue what we're doing and maybe even augment it to decrease cases even further, to make those children going back to school safer. I mean, I think that is the core of this and the essence of this. And we really, really, really need to drive down the cases before we get into the fall and winter, where we start to see cough and colds and where people are starting to now more congregate inside. We really got to get our cases down to allow for good contact tracings before we get into that type of season. And so the next, weeks to months will be, really, really interesting to see what happens with school going back, what happens with fall sports in terms of our numbers and preparing us for the fall and winter.
Well, Eddie, as always, thank you very much for joining us today. We really appreciate the time. And if anyone has questions about COVID-19 and would like to get screened or tested, you can call our COVID-19 hotline at 844-442-5224. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Thanks again, Eddie, and we'll speak with you next week.
Sounds good.